I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenny as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone.
Hello, welcome to the Hormone Genius podcast. We are going to have an awesome episode. We're going to talk about endometriosis, and we have an incredible doctor who's going to tell us all about endometriosis, Dr. Patrick Yeung, who we were just talking offline. Funny thing, and you can do this, apparently ChatGPT has found him to be the most amazing endometriosis surgeon in the state of Missouri. He said one of his coworkers had put that in, or a patient put that into ChatGPT. So we know he is an expert. In fact, I called him the king of endometriosis. I don't know if that's a good title, but we're going to dive in, Dr. Yeung, because so many women are interested in knowing more about endometriosis, and those who have had it understand that it is a complicated diagnosis and complicated disease. But the first question I want to ask you is, we know that statistically it takes 10 to 12 years for women to get this diagnosis correct, and whether or not they get it treated correctly is a whole different story. But from a historical perspective and from your journey, even in your personal career, why is it that we struggle so much to figure out that women have this disease and treat it the right way?
Wonderful. Thank you so much for that. So endometriosis, just briefly, is what? It's where the cells which line the uterus and are shed during the period are found outside the uterus. So it's cells in the wrong place. And this condition, and outside the uterus, is associated with pain and can affect fertility. And it's well documented that the amount of disease and the amount of symptoms do not line up well. You could have a little bit of endo and a whole lot of pain, or a lot of endo and no pain. We have multiple examples of both. But how common is it? I love to quote this TED Talk called "The Most Common Disease You've Never Heard of." That's endo. Everybody knows somebody with endo. And there's this hashtag 1 in 10, as the rate of endo, but that's the rate of endometriosis in the entire female population, most of whom have no symptoms. But if you have a woman with infertility and no pain, the rate of endo is at least 50%. Pain that does not feel better with the usual hormonal suppression, which I call Band-Aid therapy, the rate of finding endo is over 80%. And from our database at St. Louis University, a 10-year database, 1,000 patients, if somebody had both pain and infertility, the rate of finding endo was over 90%. And by the way, most of these women are being told they have unexplained infertility, which if you're trying to get pregnant is a slap in the face. So endo is way more common than we think. 1 in 10 is a gross underestimate. And women are being told, oh, your ultrasound is normal, your exam is normal, you can't have endo. Totally and completely not true. Even surface endo can affect pain and can affect fertility. How is it doing that when it's not deep enough to be in the nerves or affecting tubes and ovaries is a great question. But we know that the association exists, and that treating endo will improve pain, quality of life, and improve fertility. And maybe the how is less important.
So you talked about different types of endo, and maybe I heard you wrong, but I know going through the fertility care practitioner program through Creighton, they talk about, I think they call it like invisible endo or phantom endo, or something that you need to have a trained eye to see because most people would miss it. Can you talk a little bit about that? Because I'm wondering about all those who listen to our podcast who thought themselves, extremely painful periods, infertility, go to the doctor, and the doctor says, no, you don't have endometriosis. But, how common is it that, again, they do have endometriosis? It's just the kind of endometriosis that is not easily seen by maybe those who who typically are, the endo referrals, as opposed to maybe the NAPRO endo doctors?
Sure. So thank you for that. So when the disease is advanced, meaning there's a ball of it in the ovary called an endometrioma or chocolate cyst, or it's involving the bowel and there's a bowel nodule, those can be picked up by imaging because it's gone beyond the surface and there's a thickness or a mass to the disease that you can see by imaging. And now standard of care, standard practice among centers of endometriosis is even to offer a mapping ultrasound to not just look for cysts in the ovaries, but to look for bowel nodules. And that's becoming standard to help plan for surgery, to look for, again, evidence of advanced disease that you can now see by imaging and often feel on exam. But early stage endo, which is just implants on the surface that you cannot see or feel, the exam would be normal, the ultrasound would be normal, and yet the patient could have surface endo. And it's typically a black powder burn or gunpowder lesion. That's the typical appearance or description. But it can also be other colors, other forms. So it's not just black spots. It can be brown, red, white blisters. It can be really subtle. So that's what we talk about in the world of NAPRO, but also it was the father of excision surgery, this way to treat endo by cutting it out, which is what we do. We don't just burn it. We can talk about that, but we're trying to get the whole lesion disease out under the roots by cutting it out. The father of excision quoted the term near contact laparoscopy, which means to see all the endo. There's a basic premise that you have to see the endo first to then treat it. And to see it all, and including its subtle forms, you have to zoom right in. You have to do what's called near contact laparoscopy. Get the camera very close to the tissue so you can see these very subtle lesions, which are often very subtle or could be missed by or in teenagers. So on that point, we have a publication in teenagers. It's actually the largest prospective study on excision in teenagers. And they all got optimal excision, which we define as cutting out whatever is suspicious for endo in whatever form and wherever found. We looked back on almost half of patients, and the rate of finding endo again in 2 years was 0. And most of the patients were told if we felt like we treated all the disease, they didn't need to be on hormonal suppression like most people recommend after surgery to keep the disease away, basically because the disease has been removed. There should be nothing left to have to suppress. And still, there was no actual disease found when we looked back in almost half of patients. So we said, the title of the manuscript is Complete Eradication of the Disease is Possible in Adolescence Even Without Postoperative Hormonal Suppression. Well, this caused a firestorm, and we had a written criticism saying, well, you cannot get it all. You cannot eradicate it because invisible endo exists, especially in young patients. Disease that you cannot see. So we had to answer this criticism with a graph that we kind of republished, again, by Dr. Redwine, the father of excision, who showed multiple studies looking at basically the closer you look to the tissue. Again, this idea of near contact laparoscopy or distance of the camera to the tissue. And I would say if you add to that the awareness of the more subtle forms of endometriosis that we're now aware of in the last 10 years or so, that the rate of invisible endometriosis went down to basically 0. In the last study, it was 0. So we would say if you look closely, carefully, and systematically, and treat all the endo in whatever form and wherever found, the rate of missing it can be very low. And we just published our data from our 10-year database at St. Louis University that the rate of repeat surgery can be very low. It was actually under 5% in 10 years. And most of our patients took no long-term suppression post-op. So we're saying one and done surgery is possible, which no one thinks is possible. But to achieve that, I mean, there's no cure, nobody's perfect, but to achieve that result, you really have to look closely and carefully and treat all the disease.
So, Dr. Yeung, I think the analogy, and I've used this, I don't know if I think you have too, that we might say endometriosis is like cancer. It's not the same. I mean, it is somewhat similar in the sense that it's abnormal tissue growth growing in a place it shouldn't. And when I talk to patients about it, I'll often mention, if I had cancer, if you had cancer, I would want the best surgeon in the world, right? Like I would want the person who is going to go in there, and when they go in, they're like, I'm going to get every microscopic piece of cancer cells, and I'm not going to leave anything, no stone unturned. In fact, my mom had ovarian cancer when she was 59, and it was stage 3. And I'll never forget the surgeon, he explained to us that the cancer was like literally like dipping a paintbrush in a can and like taking it and flicking it on a wall. And so there was just cancer everywhere in my mom's abdomen. But he told us, he's like, I'm going to go in and I'm going to get it all. And you know what? My mom is alive. She diagnosed at 59. She's 84. And there's a reason why she's alive, because he put words into action and he really truly did the work. Now, it's the same thing with endometriosis. And this is why you have your own Restore Center for Endometriosis. And you've done over 4,000 surgeries. I know it's probably well over 15 years now you've been doing this. You're an expert in your field. And so when I talk to patients about getting this diagnosis, I want them to go to a surgeon who knows what they're doing, because of the reality of what you just explained, that doctors, unfortunately, just the regular OB-GYN world, who, God bless them, they don't know what they don't know. They haven't been trained to do the surgeries in a way that allows you to actually diagnose all of the tissue that is abnormal and to treat it appropriately. And so we have to encourage patients to advocate for themselves to get a surgeon who does know what they're doing. Can you explain, like in traditional, because obviously you went to medical school and you became an OB-GYN, so you would have gotten that training. What is the difference, and what level of extra kind of training do you think it takes in order for a doctor to get to the point they're like, I'm going to do surgeries well in this area, and we're going to, like you said, we're going to get to basically as close to a cure as we possibly can?
Wonderful. I love the way you put that. Thank you so much for that. We know that volume matters. First off, to say that, it's well published on that the amount of volume or cases that a surgeon done matters in terms of outcomes, but also reducing the risk of complications. So because of that, I decided early on to be good at this, you kind of have to focus on it, that I couldn't be doing it part-time or every now and again, which is what most GYNs are doing. If they decide to treat endo, it is a part-time thing, or up, delivering babies at night and trying to do surgery during the day. I couldn't do that. So I've focused on it. This is all I've done now, basically for 15 years, almost 4,000 cases. So we know that surgery matters for outcomes. Also, the analogy with cancer, I think, is wonderful. I've always said that I think research, publications, training, the data for endo is about 30 years behind cancer. So it's very interesting. It used to be back in the day in cancer surgery that they had this idea of optimal debulking. They would get lesions out that were more than 2 millimeters. And then the rest they felt like they didn't have to get, and that the chemotherapy would treat all of that. Now they've gone to optimal excision, or some term like that. Basically remove all visible lesions, and they've shown better outcomes for cancer. The same is true, or the opposite is true, for endo, in that, there's a belief that you don't have to remove it all. I feel like surgeons who treat endo, the way I say it is, they either give up or they don't feel the need to remove it all. Meaning they're going to remove what they can, but then whatever they don't get, they're going to do what everybody does, which is to recommend post-operative suppression that should suppress whatever they don't get. Band-aid therapy. Or for fertility, they're going to bypass the pelvis and offer IVF. They don't have to optimize the patient's own anatomy. So, but now, again, we're showing and other centers are showing that there is a benefit to and better outcomes with complete or optimal excision. And so we talk about root cause treatment or restorative reproductive surgery to remove the disease instead of band-aid therapy for pain or bypass therapy, and for the hope of one and done surgery. That's a very different surgical mindset on behalf of the surgeon. And now with our data, one and done surgery is possible. I think a very different surgical outcome for the patient. And so, I did the fellowship in minimally invasive gynecologic surgery after residency for OB-GYN. So I was very well trained in operating laparoscopically or keyhole surgery, which laparoscopy affords the benefits of seeing better, basically. You have high definition optics, you can zoom in, you can light things up, so magnification, illumination. We can see better. It's I would say the preferred route of treating endometriosis. But then did further subspecialty training to learn to cut out the endo, and I use a very precise non-contact cutting tool to do so. The CO2 free beam laser, carbon dioxide free beam laser. I don't have to touch the tissue to cut the tissue. So that allows me to scallop it off even over very delicate structures like bladder, vessels, bowel, fallopian tube, are all areas where I can treat where others often would not. So it takes training skill to be able to do that. We taught residents for most of my career. Residents would see how we're treating the endo, how it's different from most, and the outcomes from the patients, and often ask, why isn't everybody doing this? Well, it takes time, it takes training, it takes risk. You're basically treating endo on vital structures. But the outcomes are better. And so there are people who say endometriosis should only be treated by centers of excellence or centers that are dedicated to treating endo. If it's advanced, it's gone beyond the surface, involves multiple organs or organ systems, it takes a team to address those cases. Or if it's subtle but just surface, but can be subtle, especially in younger patients, it takes somebody trained to be able to recognize and treat even the subtle areas.
Such important work you do, Dr. Yeung, especially because, again, I have clients I've worked with and friends who have been diagnosed with endometriosis, and it almost seems like the thought of having to travel afar is a barrier, or the thought of the unknown, and everyone else is talking about how, the doctors that they see, we're just going to laser it off, or we're just going to cauterize it, and get pregnant quick because it'll come back, And so it's just this interesting perspective, and I want to hear what you have to say about that. But first, I do need to make sure I give a shout out to our podcast partner, We Heart Nutrition. So Teresa and I, we love their supplements. We talk about them every episode. And so if you are looking for a high quality supplement from a company that really values family, women, children, please visit We Heart Nutrition and get 20% off your first order with the code GENIUS, GENIUS. That's at We Heart Nutrition, 20% off your first order. So, Dr. Yeung, what kind of advice would you give to women who have been told, you have endometriosis, we'll just cauterize it, we'll get you pregnant quick, and then it'll probably come back. But by that point, you probably have enough kids and, it won't matter as much. Obviously, it's very frustrating and probably very opposite of what you would think, because that doesn't seem very restorative. But what kind of advice would you give to women who are really just trying to weigh out the pros and cons? We know that there's restorative reproductive surgeons, maybe the cost, the wait list, the distance. So what kind of elevator pitch or sales pitch in a way would you give to these women who are trying to really discern which path to take?
Well, most by the time they come to me, I've already tried the usual band-aid therapy for pain, like birth control pills. Nowadays, actually, the newer FDA-approved medications for endometriosis-associated pain are actually causing a state of chemical menopause with a lot of side effects. So they've tried the Band-Aid therapy or the bypass therapy with IVF, and they're looking for a root cause treatment in the hope of one and done surgery. But the status quo, I call it, recommendation to women is be on birth control pills to keep the endo from growing until surgery. And then on the back end, after surgery, to keep it away, which again, we have shown is not needed. And it's also not proven that it does prevent any kind of progression of the disease. And then wait until you want to try to get pregnant, and then try to get pregnant. And if it doesn't work out, then get the surgery and then get pregnant within a year, because it's going to come back, quote unquote, in 2 years. So yes, the rate of repeat surgery after the usual burning, where they're just getting the tip of the iceberg and not burning their vital structures, the rate of repeat surgery is 50, 60, up to 80% in 1 to 2 years. So expect to have surgery every couple of years and get pregnant right away within the first year before it comes back in 2 years. Again, we're showing a very low rate of repeat surgery in 10 years without the need for long-term suppression post-op. And so we would rather get it early before it's progressed, help patients feel better. Maybe because if it's not there, it can't grow. We've done something to preserve later fertility and allow the patient and say to the patient, they can get pregnant when they want to. There's no rush to have to get pregnant, but plan your family with the right person at the right time.
Dr. Yeung, can you explain, because I think a lot of people are told that birth control will kind of like slow down the disease, prevent more growths of endometriosis. Can you just give an explanation of kind of your understanding of that mentality that birth control like kind of does in some way treat endometriosis by either slowing the progression or halting the progression of the disease? And is that really true?
So we think that estrogen activates endo. So all of these types of hormonal suppression, whether it be chemical pregnancy, which are really, whether it be a combination pill or a progestin-only pill, which is synthetic progesterone, are high in the counter hormone to estrogen. Again, whether it be progesterone or a progestin, which is synthetic progesterone. So they're trying to block estrogen. That's the category of what I would call chemical pregnancy or birth control pill type of regimens. The newer ones, again, are causing chemical menopause to, again, reduce, they're actually shutting down the entire female axis to create no hormones and thereby reduce estrogen. But that strategy, I'm calling that Band-Aid therapy, to basically reduce the action of estrogen, might reduce symptoms. At best, you feel better if you can tolerate the side effects of the medications. But it's actually doing nothing to the actual disease. And to highlight or illustrate that, there were some studies done by a French group in the early 2000s or mid 2000s that looked at if a patient needed hormonal suppression or birth control pills earlier in their adolescent years or a longer time in adolescence because of pain, for in those patients, the rate of finding advanced endo was higher when they were adults. So it did not block the progression of endo to become advanced endo later. And in fact, their conclusion was the need for suppression for pain earlier and longer when the patient's younger might be a marker for more advanced disease later. Bottom line is, it is in no way proven that hormonal suppression or reducing the amount of estrogen does anything to the actual disease, much less prevent progression or recurrence. You might feel better longer, but I think it's doing nothing to the actual disease. So it could actually be growing while you're feeling better.
So important for women to know and understand that. And again, it's not explained, nor is it truly understood clearly. Dr. Yeung, I'm wondering, do you have just a Rolodex? I know you've met with so many couples and women, close to 4,000 cases, you said. I mean, are there some women, some of the stories of these women that you've done surgery with that just stick out in your mind and you go back to them kind of time and time again? It might be hard because, again, you've worked with so many, but can you kind of walk us through a case? A woman comes to you, you serve them, serve her, and then kind of what follows that just kind of sticks in your heart.
Wow. I mean, that is so well. Okay, I guess I'll start with our own story,
Yeah, please. Great idea.
if that's okay.
Please. We would love that.
My wife had painful periods her whole life. Thought it was normal, was told it was normal. We tried to get pregnant from day one. After a year of trying, she said, maybe I have endometriosis. I said, no way. She had bad, severe, advanced endometriosis. She had one surgery to remove the endometriosis and then multiple surgeries to prevent adhesions. She now feels great. She's pain-free, and we've had recurring fertility. We're trying to pay that forward. That is really the bottom line reason for Restore Center for Endometriosis. So just to make that point there, we believe that the way to get to the hope of one and done surgery and why we think our outcomes are so good is because we're trying to combine the best of cutting out all the endo or optimal excision, which again, very few do well already. But even if you can cut out all the endo, that is still not enough. That is still only one half of it. The other half is preventing adhesions, where things can stick after surgery. And that's going to be bad for fertility and pain. And again, my wife had multiple surgeries for adhesions. So we're trying to pay that forward so that women don't need so many different surgeries for adhesions. And that is how, when you do both well, combine the best of optimal excision and adhesion prevention, is how I believe you get to the hope of one and done surgery. But I steal my wife's phrase all the time, that helping a patient who has debilitating pain, cannot function, missing school, work, planning their vacations around their period, to quote unquote get their life back, or to help a woman who has been struggling with, just such the terrible experience of infertility, become pregnant, has eternal value. There's nothing better. We have so many stories, reviews, pictures on the baby board of women who say they feel better, got their life back, able to engage in the marital embrace again, or get pregnant, and sometimes oftentimes multiple times. I mean, what a blessing. There's nothing better. I was in training a long time. I always say I'm a slow learner, but I love what I do. I did 2 residencies and 2 fellowships to do what I do, but I love it, and there's really nothing better.
It's so amazing that I think for patients, it's got to feel like just doubly good to go to a doctor who actually they can trust and know that they're going to do an excellent job, but also understands them because you understand it because you have such a personal, close story to endometriosis. And as I look behind you, you've got 5 children. And I mean, like you said, eternal value. Can you imagine how many patients out there right now who, whether they went to you, Dr. Yeung, or another endometriosis surgeon that cured their endo or did the best job they could and they have children because of it? I mean, the gratefulness, the gratitude to that, I mean, is unmeasurable. It really is. And so this is such important work because we're talking about not only pain and the quality of people's lives, we're talking about their ability to do the most important thing that gives purpose and fulfillment in life, which is family. It's so beautiful and valuable. I know for sure I had a patient that went to you years ago, actually. It's been, I think, probably 3 years, but she had done endometriosis surgery with a previous surgeon and was still trying to get pregnant, wasn't working, and had heard about your work. And so she came to you, and she has a little boy now. And every time I see her, every time, I mean, it might be the only child she ever has, right? Like she knows that. But every time I see her, like she just oozes gratefulness and gratitude for that child because she knows that had she not gone through what she did and the effort that she went to get to you and to go through all this treatment, she may not be holding this little child. So it's incredible. It really is. And I love that you have that connection to your wife in the story. It just makes it all more meaningful.
Praise God. So, sorry, getting choked up just hearing your story. But there's so many like that. And, going through infertility was really hard. We went through it for 5 years. During that time, my wife said, I feel passed over. I can't imagine what that feels like. And not everybody's story turns out the way ours did. But I tell patients often, I'm here to tell you, you are not passed over. You are not forgotten. I don't know what the outcome of your story is going to be, but there's a purpose and a reason for your story, even if it's just to get some answers. And my wife would often say that, she wanted to feel better. She wanted to know if she got pregnant or not, but she wanted answers. And not having answers is insult to injury when you're going through it. And she would say, now after the fact, getting the answer, getting the anatomy taken care of, which for her was surgically, was such an important part of her journey and her healing process. Again, the name Restore Center for Endometriosis came from her, this word restore. And to be a part of that, which is really, God is a divine healer. I just work here. I always say my job is to kind of set the table and then offer it up. But getting answers, feeling better, usually having the chance for fertility and recurring fertility is all so important. Again, we talk about restorative reproductive surgery, finding the problem, the root cause issue, removing the actual disease. When you talk to patients about it like that, first off, they're like, why haven't I heard about this sooner? They're tracking, they're on board. They want the diagnosis, they want the disease removed. But many in the medical industry, I call it, whether it be big pharma for pain or big fertility like IVF for fertility, they're not on board. But really, if you think about it, that's where the money is. In long-term medications that start in teenage years for pain, or 20, 30,000 every time you want to get pregnant. It's actually, I joke, one and done surgery is not a very good business plan, actually. But that's what we're hoping to achieve for patients.
Mm, so important. It kind of feels like the David and the Goliath situation, doesn't it? But we know who wins. We
There
know
you
who
go.
wins. Yeah, I applaud you. And I think a lot about, just because we hear the same information over and over and over again, it doesn't mean that that information is true, in regards to IVF or birth control as being women's health care, quote unquote. I am really into this idea that, our brain believes what it is told all the time. Our brain is kind of a little lazy. Like it's going to believe what it's told constantly. And so a personal goal and mission of mine, just in my professional life, is we want to balance out that noise. We got to be kind of loud. We got to be loud about that. And that's what Teresa and I are doing in this podcast. We got to make some noise for the
Wonderful.
sheer fact of, understanding that that's what our brain actually needs to make sense of all this. So, Dr. Yeung, we're just so thankful that, again, you took time with us today, shared, your expertise on endometriosis, but that you also shared your heart behind this and the why behind this mission. And, nothing strikes deeper than doing this for your family, doing this for your bride, and using this to further the mission of restorative reproductive health. So, we're so thankful that you're here with us today. And I have my last question.
Oh, well, can I just add
Yes.
to that point about IVF? Thank you for that. IVF, I like to say, if it's seen as the be all end all or as the best option, it very quickly becomes the only option.
Yeah.
And I like to make the point or tell the story that, so I had an IVF director to ask me, who is the most important person in the IVF center? So she posed a question. Well, maybe you get to guess. Do we have time?
Yeah.
Who do you think is the most important person in the IVF center?
Well, you'd hope the patient.
Well, first and foremost, it's not the IVF director. It's not the person who got into med school, went through med school, did fellowship, residency, subspecialty training, now owns and directs the IVF center. It's not her. And it's not even the patient. She posed the question and then gave the answer that it's the embryologist. It's the lab director. That to me really highlighted that that is where the action is. It's all in the lab. And if you think about it, the patient becomes really just a producer of the eggs. And the IVF director just becomes the person who kind of almost as a technician just transfers the embryo made in the lab back to the patient. You know, back in the day, 30 years ago even, and only 30 years ago, 80% of fertility specialists were surgeons. Now in 30 years, it's totally flipped. Now it's only 20%. All the actions in the lab. And we've stopped looking for root cause issues and removing disease and optimizing the anatomy surgically. Again, because it takes time and expertise and has some risk. So yes, I think women deserve better. Women with infertility deserve better. Women with endometriosis deserve better than the status quo.
So true. And I think as time moves on, we're going to hear more and more about restorative reproductive medicine. And I know you're a mouthpiece in that movement and our podcast and a lot of our close friends that we've met along the way at conferences with the same mission and the same heart. So true. And it's very important, like you said. And that's a great point about what you said about the quote unquote most important person in the room. I never had thought of that. That's such a good point. That seems a little weird, Doesn't seem quite right, if you think about it. So important to state for sure.
Yes.
Well, as we wrap up this episode, Dr. Yeung, I'm going to ask you the question we ask every guest as we close. Dr. Yeung, what do you wish every woman knew about her hormone genius?
Yeah, so a little bit like I just said, but as you said, I really think women patients these days really have to be their own best advocate to know that the voices that are out there, the status quo is not adequate. It's not the only way. It's not the best way, and other options exist. There's a lot of talk now about restorative reproductive medicine. These big organizations, again, big pharma, big fertility are trying to take down restorative medicine or discredit it. But just to know that, this is really back to the basics of medicine. Somewhere along the line, we kind of went off track with Band-Aid and bypass therapy. But to know that we can practice good medicine, we can look for underlying disease conditions, remove disease, help patients feel better, lead to natural fertility, and it works. Again, keep asking questions, be your own best advocate, and again, know that women with infertility deserve better, women with endo deserve better than the status quo.
Yeah, it's interesting. We didn't have to give it a name. It should have just been what medicine was in women's health. It didn't need to be called anything. It's that we've messed it up. And so now we're like trying to go back to the basics, and we gave it a name because we almost had to get people to pay attention. So it's frustrating because you're like, it should have just been good women's healthcare where we treat the underlying problem and fix people. It's frustrating that we're here, but we are. And so we're going to keep shouting out to the rooftops that, people like Dr. Yeung are out there. And in light of that, would you please tell everyone where you're at? Dr. Yeung, where's the Restore Center for Endometriosis? How do people get in touch with you? Are you on social media? Those sorts of details.
So the website, we put a lot of work into the website, has a lot of good information, patient stories, testimonials, that kind of thing, and our approach and our publications. So that's restoreendo.com. or restore-endo.com. We are present on social media as well. So my personal kind of a surgical account is at PPYEUNGJRMD, PP Yeung Jr, MD. There's also a Restore_Endo website for the practice, which is a little bit more, that's run by a functional medicine expert. And so we talk about surgery and optimizing the anatomy, but the other two areas important for general wellness and fertility, which really go hand in hand, is optimizing the hormones, which has to be properly timed to the cycle. We call that the targeted hormonal evaluation and support. But then also, I think there's really something to this functional medicine piece, talking about food as medicine, deficiencies, the importance of supplementation, and proper nutrition. All that's important as well. So all three are important for the global approach to, or a comprehensive approach to wellness and fertility.
That's amazing. And we'll have to have you back to talk about that more, apparently, because that's a whole nother podcast in and of itself. But thank you so much for your time, Dr. Yeung. We really appreciate it. And hopefully we'll have you back real soon.
Thank you both.
Thanks for listening to the Hormone Genius podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel. So if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.